your one-stop surgical solution empowering excellence across oncology, bariatric, thoracic, gynecology, urology, gastroenterology with innovative and reliable instruments. From precision cutting tools to advanced energy devices, we deliver comprehensive solutions for modern surgical needs, ensuring safety, efficiency, and superior patient outcomes. Introducing Myris, range of stapling products. Powered endoscopic linear cutter. Endoscopic linear cutter. Monic trocars. Eliaro trocars. Eliaro bladeless trocars. Mesic energy device. Mesic compact ultrasonic. Mesic ultrasonic. At Merrill, we don't just innovate, we empower. Together,
good evening, everyone. On behalf of the Amasi, would like to welcome you all for yet another session of Amasi Lens, where we have either live surgery or live minimally edited video performed by an eminent faculty, a good teacher, based on few tips and tricks where not even a young budding surgeon would understand, but even may get benefit. A consultant would get benefited with these. Today we have none other than Dr. Om Tantia. I don't think he requires any introduction. A teacher to many, a good-hearted soul, a past president of Amasi. Today is going to show us a minimal edited video on the mini-gastric bypass. To moderate the session, we have three eminent consultants. Dr. Debarshi Sharma, who was past Honorary Secretary of Amasi from Delhi. Dr. Mansingh Adnaik, the eminent bariatric surgeon from Kolhapur, and Dr. Kedar Patil, bariatric and hernia surgeon from Pune Hospital, Pune. Before we start and hand over to moderators, I would request Pashupati to put up a slide of forthcoming events of Amasi. So the main mega event what we always bank is AmasiCon, which will be going to be there from 20th of August to 31st August at Jaipur. So I would request all to register for this conference where you are going to have the eminent surgeons performing live surgeries, good panel discussions and symposiums, and you would get to see many foreign faculties giving their experiences and sharing their thoughts about minimally invasive surgery. Next, online we have online CME series which happens on first Monday of every month. This time is going to be the Dr. Chernowski from who's going to talk about advanced rectal tumors and if it's involving bony segments, what would the approach? This will be on 6th of March at 8 p.m. What we are doing Amasi Lens today. The next Amasi Lens would be done by Professor Gyanchand, who is a professor in endocrine surgery at SGPGI, who is going to speak and tell us, show us about robotic thyroidectomies, which will be on 20th March at 7 p.m. We have the specialized minimal access courses in special fields. So colorectal MMAS will be held from 24 to 26 March. Dr. Prakash Krumkur is the course director at Kochi. So it is initially it will be online from 24-26 and then physical from 20th to 30th March at Kochi. So if interested people, please join. Next MMAS will be on HPB surgery. The online the lectures will be from 31st March to 2nd April, while physical will be from 4th April to 6th April. It is organized at Jipmar, Puducherry by Dr. Piju Potakat. Then much awaited MMAS in hernia, which will be held in Jaipur at the end of the May. This will be the course coordinator would be Dr. Rajendra Mandia. So thank you all. So I hand over the screen and proceedings to the moderators, and I welcome you all. Tantia sir, I think we are all eager to see the basics, tips and tricks about mini gastric bypass.
Uh,
Good
Over to
evening.
you, moderator sir.
yeah, before Dr. Omtatia start on OAGB,
Yeah,
I'm Dr. Chaudhary because
welcome
our
sir.
president, Dr. Kalpesh Jani, he's traveling from Baroda to Bhubaneswar to attend skill course tomorrow morning. So I now request our expert panel, Dr. Deborshi Sharma, Dr. Kedar Patil, and Dr. Mansingh Adnaik to moderate this session. And I request our honorable speaker, Dr. Om Tatia, past president of Hamasi, who took on the podium. I will talk on the mini gastric bypass for OAGP. Dr. Tatia, please.
Good evening, everybody. Good evening, moderators and other audiences, members in the audiences. To begin with, I would like to thank the Amasi College of Amasi Minimal Access Surgery for giving me this opportunity to be here this evening and share my experience with you all. Thank you once again. Uh, I'll be talking about mini gastric bypass. I start my presentation here. PowerPoint. Yeah, can you see the patient particulars?
Yes sir.
Okay. This is a male patient, about 62-year-old, weight of 139.2 kg and a BMI of 49.9. He didn't have diabetes, but he had hypertension and he was a non-vegetarian. He tried a lot to lose weight by conservative management, and he was given option for medical therapy, but he opted for bariatric surgery because the cost of medical therapy would have been too high. So he was counseled for mini gastric bypass. All the blood parameters like CBC, sugar, liver profile, coagulation profile were normal. Uh, his C peptide was also well within normal limit. His nutritional profiles were also normal. Vitamin D3 was a little low, otherwise, rest of the things were normal. His ultrasonography suggested hepatomegaly with grade 2 fatty changes. Upper GI endoscopy, which we always say it is mandatory in any bariatric surgery, uh, it showed mild antral erosive gastropathy, and he was taken for mini gastric bypass. That was the plan. Now, when we talk about mini gastric bypass, we always avoid mini gastric bypass in patients who have unacceptable risk of coagulopathy, uh, also uncontrolled coagulopathy, ventricular output function defect, liver cirrhosis, especially child C. Primary short gut is another contraindication for mini gastric bypass. Severe inflammatory bowel disease, we avoid mini gastric bypass. Barrett again is something where we avoid. Symptomatic large hiatus hernia is also a very important situation where we avoid mini gastric bypass. Other conditions are like normal, in where we also avoid bariatric surgery, like unstable psychopathological condition, drug dependency, and adolescents. We also avoid mini gastric bypass in young unmarried female who want to have pregnancy and patients who are below 40 BMI without comorbidity. Preoperative protocols are the standard one. It is a multidisciplinary approach, including psychiatric workup. We encourage the patient to have a VLCD, very low calorie diet, for at least 7 days prior to surgery. This helps us in two ways. Number one, it gives us an assurance that the patient is a compliant. Number two, it makes the liver a little floppy. So VLCD is very important. Earlier, we used to give it for 14 days, but we realized that 14 days patients do not take, so we have reduced our protocol to 7 days. DVT prophylaxis, like with enoxaparin, sodium 40 units subcutaneously 12 hours before surgery, that is our routine protocol. Antibiotic prophylaxis as per the hospital protocol. Our hospital protocol is cefoperazine sulbactam combination. When we start doing MGB, when we venture into MGB, we must remember two things. Number one, MGB is not RYGB. In RYGB, the pouch is very short and very small, and the anastomosis is also very small, 2.5 centimeter anastomosis. But in MGB, the pouch is long and wide with a very wide anastomosis. We also must remember that MGB is not a sleeve gastrectomy. In sleeve gastrectomy, the gastric tube is too tight. We hug it nicely on a 36 or 38 French bougie. But in mini gastric bypass, the tube is wide, not as narrow as sleeve, and we have to stay away from OG junction. This step is very, very important. Patient positioning and securing. We put the patient supine on the OT table. We put dynamic DVT compression device, strap the patient very properly. This is very important. See, the patient has already been put these DVT stockings, and then we apply these DVT compression devices, and then we put this crepe bandage, and now we tie the patient very properly, strap the patient very properly to the OT table. These these bands, you can see, they are heavy engineering band, and they can take a load of about half a ton. These straps can take a load of half a ton. When we put the patient, strap it nicely, then check OT table up, down, side, every possible ways that the patient is not moving, and then only we start the surgery. These are the port positions. Our optical port is about 18 centimeter. You can see the B, that is the optical, optical port is about 18 centimeter from the xiphoid process. We don't take umbilicus as the standard referring point because umbilicus in obese patient can vary in position. It can be as low as mid-thigh or it can be at a normal position. So, but bony landmarks are the standard fixed landmark. So xiphoid is the position that we take. About 18 centimeter from xiphoid, we put our camera port, that is about 12 millimeter camera port. Then another port is 12 millimeter sub-xiphoid port. This is used for our first firing. Then another 12 millimeter port in the right and left mid-clavicular line, right and left mid-clavicular line, these two ports. These are also 12 millimeter port. And this port in the left anterior axillary line, 5 millimeter, is the port for retraction. Surgeon stands on the right side of the patient here. The camera assistant stands here. Patient is in supine position, nicely strapped. The monitor is here, and the assistant surgeon is standing there. So we gain access in the standard way. I use a Very's needle and gain access. See the enlarged liver, you can see. Liver is fortunately good, even for this 49 BMI. The fibroscan was, I think, F2 or F3, I don't remember. Then we put another 12 millimeter port from epigastrium. You can see it corresponds a little above the inferior border of the liver. This is the third port, 12 millimeter. This is positioned in the left mid-clavicular line. And the first thing that we do is, after we put all the ports, we look for where is the crow's foot. So this is the position of the crow's foot. And we also make sure where is the position of the pylorus, because our division will start somewhere between the pylorus and the crow's foot. 4 centimeter proximal to pylorus. We use harmonic scalper or any energy device to gain access. Here, when we take a ultrasonic device, we make sure that the active blade is looking towards us. It is not the other way around to avoid injury. And we try to gain access into the lesser sac. Sometimes there are adhesion between this part of the stomach or the antrum and the pancreatic capsule or sheath, and it may be difficult to gain access. But we have to stay close to the stomach and gain access. So now you can see a flimsy layer in between. Downward and lateral traction of the antrum by the assistant helps a lot in opening up these planes. So that this traction by the assistant is very, very important. And now you can see the lesser sac is getting opened. We make a reasonably wide window. We make a reasonably wide window and make sure that there is no adhesion between the antrum and the pancreatic fascia. Absolute hemostasis at this juncture, because sometimes, or rather more often than not, this fat of the lesser omentum, it oozes, some nasty oozing. So perfect hemostasis. Now you can see there is no adhesion. Now our first stapler comes from the epigastric port. It's usually a 45 millimeter load. I always take a gold cartridge. Gold cartridge is approximately, I think, 4.2 millimeter is the leg length. And since the antrum is thick, you take a gold cartridge. We must make sure that both the anterior and posterior wall of the antrum are equally taken into the stapler cartridge. If we don't take this equally, then there is a possibility of twist at this point. And we often say that the seed for twist is sown at this point itself. If we don't take the anterior and posterior wall in equal proportion, there is possibility of twist. Now make sure that there is no adhesion. We check there is no adhesion. Yes, no adhesion. It is clean. Absolute hemostasis. And now we introduce our next stapler. This is taken from the right mid-clavicular port, 12 millimeter, and this is 60 millimeter load. Again, a gold cartridge, because here again, antrum is quite thick. And we stay away from the crow's foot. That is very, very important. We don't want any narrowing at this position. We don't want any narrowing at this position. And now we hold the tip of the gastric tube, give it a downward and lateral traction. Once we engage the next cartridge, this time it is a blue load, 60 millimeter. We give a downward and downward traction so that the whole stomach comes in an anatomical position. And then we engage, fire. We have to wait for at least 30 seconds before we fire the echelon gun. Here we make sure that the staple line is away from the point the vessels dip into the gastric wall. That is very, very important. See here, the stomach line, the staple line is away from the point where the vessels are dipping into the gastric wall. And by this time, we have already engaged the 36 French bougie. And we must make sure that this fold is straightened. We don't want any fold in the staple. And that's the bougie in position. And see how I'm at least 0.5 to 0.75 millimeter centimeter away from the bougie. In this case, I'm quite uh, lucky that all the staples are coming from the right hypochondrial port. Sometimes we may not have a proper angle of the stapler to fit into to engage properly. In that situation, we shift the camera to the right hypochondrium, and the stapling we can do from the midline port. So, or the erstwhile optical port, we can pass the stapler and we shift the camera to the right hypochondrial port. Now, the next step is very important. Next step is we create a retrofundal window. We create a retrofundal window. That's the fundico area, just inside the peritoneum. Our idea is to make incision only onto the peritoneum and rest separate the tissue with the blunt grasper. Open the prong and separate the tissue. We don't want to make any unnecessary division, blind division where we can't see. Because if it bleeds in this area, it bleeds torrentially. So just very, very carefully, we have to be careful about short gastric, posterior short gastric. We have to be also very careful about spleen. So we create this window. Sometimes there is a tendency to dissect medially, and this dissection proceeds medial to the left crus. See, there was in my situation also there was a slight tendency to dissect medial to the left crus. That's an ominous area. We shouldn't go there. This is an ominous area. We shouldn't go there. So our dissection has to be a little. We shift our attention a little laterally. Now I'm shifting a little laterally. See, there. That's the area lateral to the left crus. Lateral to the left crus. This area is safe. If we dissect medial to the left crus, we are likely to enter into the mediastinum. So we create this window, put our instrument inside, as anesthetist assistant's instrument inside, and then we fire this stapler from the left hypochondrial port. From left hypochondrial port, we fire this stapler. So see, we are using epigastric port for firing the first stapler. We are using right hypochondrial port to fire 2, 3, 4 stapler. Then we are using the left hypochondrium to fire next 1 or 2 stapler. I'm now using a gold finger to create this space, to create this window so that my stapler engages very nicely and freely. We have to be very patient at this position. Any hurry, anything blind is not acceptable. There is a very small flimsy layer you can see up there. And if we don't divide, if we don't make an opening there in this flimsy layer, the stapler gun will not go. So we have to divide this, and you can see the spleen there. We have to be, again, very, very careful. Very, very careful. We don't want any splenic injury. Very gently. Very, very gently. We have to be, patience is the key word. It may take a minute or so. Now you see, nice area, nicely done. We enlarge it. Now you can see this window. We enlarge it. You can see the diaphragm, and we engage this. Again, a point of caution, we have to be very careful about the spleen. We have to be very careful about the diaphragm. We don't want to make a hole in the diaphragm. We don't want to cause injury to the spleen. close it nicely. You can use a 45 cartridge also, and then we divide. We make sure that there is a complete division. That is important to avoid a gastrogastric fistula. Put a piece of gauze up there. And we make sure that there is absolute hemostasis at this position. Before we jump onto the making the gastrotomy, we have to make sure that there is absolute hemostasis. Now we pay our attention towards this gastric tube. We have to divide these fat from the posterior wall of the stomach because our anastomosis will be coming here, and we don't want our anastomosis on the fat. So from posterior wall of the stomach, we remove all this fat for at least 45 millimeter. When we are removing this fat, we must make sure that in the spirit of removing, we don't go towards the lesser curvature. If we go towards the lesser curvature, we are likely to injure the feeding vessels. So we don't go towards the lesser curvature, we go towards the neo-greater curvature laterally, because the bowel loop is again going to come from the lateral part of this stomach tube. So now I think we have done almost 45 millimeter. And here again, you will notice that my harmonic, the active blade was up. Now we make a gastrotomy. I make a posterior gastrotomy, and the location of this gastrotomy is exactly in the center between this angle and this angle. So it is almost in the center. We must make sure that we have opened the stomach lumen. We see the bougie, and then only we are happy. Now it is time to fish the bowel loop. We reduce the head up a little bit and retract the omentum towards the right side, upwards and to the right. And that's the inferior mesenteric vein one can see there. Once we have identified the inferior mesenteric vein or the fixed part of the jejunum, we know that's the DJ. Again, you can see the inferior mesenteric vein, and that's the fixed part. So we start measuring. Oh God, I made a small bleed up there, but that's a very small bleed. That's a small bleed. And we measure. In this particular patient, this patient is almost a super obese, male patient, almost a super obese, non-vegetarian. So I'll be taking about 180 centimeter of the BP limb. So 5, 10, and then we have a mark on the instrument. After a couple of centimeters, then we start taking 10 centimeter every time. You can see there is a mark. So we measure 10 centimeter each time. It's good to hold the bowel at the antimesenteric border. We take our time. Don't hurry, because if it starts bleeding at this position, it makes a mess of everything. We don't want any injury into the bowel. We don't want our instruments to enter into the bowel. These super obese patients, there is tremendous amount of torque on the instrument. So have to be slow. A small tip to my friends: in super obese patient, there is a big torque on the instrument. So when we are doing the upper abdominal part of the surgery, then we point our trocars towards the upper abdomen, And when we are doing the lower abdominal part, then we remove the trocar, reposition them, and uh, point them towards the either neutral or towards the inferior side. So we can avoid torque by doing this. This is very important, especially in the epigastric trocar, because in the epigastric trocar, we have to have it looking up in the upper part of the abdominal surgery and looking down when we are doing the suturing. So I think 170 centimeter we have measured, and we reorient the bowel a little more, and approximately 10 centimeter from the point where my colleague has hold the bowel, reorient the bowel a little more, bring it more towards the left side. So we must remember that these loops of bowel, they are the biliopancreatic limb. Now I hold the bowel a 5 millimeter towards the posterior side to the antimesenteric border and make this anastomosis. I will explain to you why this is posterior. See, the bowel is normal anatomical position of the bowel. This is the anterior surface, and that is the posterior surface. Now, when we take the bowel up for anastomosis, the posterior surface is looking towards us. So we have to make a posterior anastomosis, gastrojejunostomy, posterior wall of the stomach to posterior wall of the jejunum. So this opening has to be posterior. Now we engage it, take this up, ask the assistant anesthesiologist to withdraw the bougie, engage it. A small tip of caution is we must not force the stapler in. If there is a resistance, if the stapler is not going smoothly, there has to be something wrong. We must rectify it and then make the stapler slide in. Now, both jejunum and the stomach equally engaged, and then we rotate the stapler anti-clockwise to make sure that the neo greater curvature is away and is not included in the staple line. And then we staple, create the anastomosis. Inspect inside that there is no bleed. We ask the anesthesiologist to pass the bougie again, so we confirm that the anastomosis is complete. And then we close the gastrotomy and the enterotomy. My take is always secure the posterior angle. I always do single layer extramucosal anastomosis. And I always secure the posterior angle first. Now, since I've made the gastrotomy posteriorly and this staple line is lying anterior to the gastrotomy, you will realize that this staple line doesn't fall into the lumen of the anastomosis. That's very important. That is important in the sense that my personal feel is that it avoids a little bit of, it avoids a leak, and also since staple they remain there, it avoids incidence of marginal ulcer. Though there is no literature onto this, this is my personal feeling. Couple of stitches to secure the posterior part, posterior angle. Absolutely nicely positioning is important. The slight eversion of the mucosa, I have to correct it. Now my needle will come onto the anterior surface. So it gives a very secure closure, and the staple line doesn't come into the lumen of the anastomosis. It's a very secure closure. So I take one more bite, close it here. I'll tie the knot. See, this is the problem when you try to save on a suture length. A long thread. So we cut it, keep one leg long, and then we come onto the anterior angle. We secure the anterior angle here. This angle is nicely secured. I normally use a Vicryl, 20 Vicryl for this. We can use PDS also, which is a very good suture material. I don't use any barbed suture for the closure of this gastrotomy or the enterotomy. See, this staple line doesn't come in the lumen of the anastomosis. This is important. Extramucosal sutures. Just a couple of more, and our job will be done. if you see this stomach tube is almost 22 centimeter long. We have measured this stomach tube so many times. It is always between 18 to 24 centimeters. So on an average, it is 22 centimeter long from OG junction. A stomach tube about 22 centimeter from the OG junction, even with a looped anastomosis, should not have reflux, should not have, biliary reflux, I mean to say. So this completes our closure. I go one or two bite beyond it and secure the angle again. Now I will secure one bite. Now I'll secure between these two. And this completes my job. See, the whole thing sits very nicely. And you can see the loop. You can see this entire loop and the lie. It's a very, very smooth lie. And it's a good T junction. So this anastomosis is complete. We cut it. Then we pass the bougie to make sure that the anastomosis is complete. Absolutely fine. I think I must take a suture there. I will do that. Now we pass the bougie, remove the needle. You can see the bougie nicely negotiating through the anastomosis, and we do the methylene blue leak test. No leak. Posteriorly also no leak. Absolutely no leak. We check for that small bleed from omentum and it has stopped. So again we check for any bleed from the stomach tube. No bleed. Absolutely dry. Absolutely dry. Then we remove the gauze. We put a drain. We always put a flat drain. Put it at the apex of the division. And this completes our job. This completes our job. Now, I would like to give some tips for a safe mini gastric bypass. First tip is antral division has to be 3 to 4 centimeter proximal to pylorus. That is the reason we look for pylorus and the crow's foot in the beginning of the surgery. If we go too high up, like this point, we don't want to go this high. This is the crow's foot. We don't want to go this high. And this is the position where we start creating our stomach tube in the Roux-en-Y gastric bypass. We don't want to go this high because this is akin to the short Mason's loop where there is very high incidence of biliary reflux. Because in this case, the anastomosis will be just close to the OG junction. So we don't go too high. We maintain the sanctity of the crow's foot, because this crow's foot is the vessels from the crow's foot are the one which supply the stomach tube. Here, see, the sanctity of the crow's foot was disturbed, and you can see the dusky color of the stomach tube. So we had to excise this part of the stomach tube. Sometimes there is a difficulty into entering into the lesser sac because of adhesion, like this. This patient had adhesion. So if we force our way to engage the stomach into the uh, stapler, we will end up having only the anterior wall of the stomach into our stapler. So it's better to come onto the greater curvature side, see nicely, pass a gold finger, and make sure that the whole thing is adhesion free. And now we can negotiate the stapler, have both anterior and posterior wall in equal amount engaged into the stapler. Any shortcut on this will lead to twist in the stomach wall. First firing, both again I say both anterior and posterior wall should be equally engaged. Otherwise, you see there is a twist. This angle should look here. This angle is looking up because there was a twist, and this twist was because anterior and posterior wall were not in equal proportion engaged into the stapler. Don't divide more than 60% of the antral width. If we divide more than 60% of the antral width, it may lead to obstruction in the remnant stomach. Like in this particular patient this video was shared by my friend. There was obstruction because more than 60 or 70% of the antral width was divided, and the remnant stomach was used. They did an antrostomy to salvage the condition. Another very important tip is don't use any energy source on the stapler. You see on the left side of your screen, again, a very nicely conducted mini gastric bypass. The surgeon has made a very nice tube. And then what is he doing? He is using a bipolar at the staple line to have an hemostasis. See, and what happens after 8 days? Precisely at the point where he had fired the bipolar, the patient is having a leak. So the lesson we learn from this is that no energy source on the staple line. If there is any bleed, we can always suture it. This is the ideal pouch. Ideal pouch is a wide pouch. It is a long pouch, about 22 centimeter long, coming almost to the level of the transverse colon or maybe a little below the transverse colon. It should be a centimeter or more away from the OG junction, and one should be able to see the entire neo-greater curvature or the staple line forming the greater curvature, neo-greater curvature in one single frame without rotating the without rotating the gastric tube. And the anastomosis should be nice. It should be no tension on the anastomosis, and the lie should be perfect. The tip of the gastric tube, the tip of the gastric tube should not look like a bird beak. It should not look like a bird because we have to create an anastomosis here. It should be rather looking like the cobra head, so that this part is wide. We can have a nice anastomosis, good vascularized anastomosis. I was talking about making a gastrotomy onto the posterior wall. Now, to explain the same again, see, this is the normal lie of the intestine. Bowel loops are coming like this. The bowel is like this. This is the antimesenteric border. When we take the intestine up for anastomosis, the anterior wall goes posteriorly and the posterior wall looks up, looks towards you, that is become anteriorly. If we make any opening here, enterotomy here, see what happens. Watch this video. Now see, the enterotomy is being made exactly at the antimesenteric border. Now we engage the stapler. The stapler is engaged here, and the surgeon goes up. And you see the anterior wall has gone posterior, and can you see there is a twist here? There is a twist here. So that twist has to be rectified. And if this twist remains, it can cause vomiting and it can cause obstruction of the efferent loop. So that is the reason we make enterotomy onto the posterior wall, because when the bowel loop is taken up, this posterior wall is looking anteriorly and it snugly comes in contact with the posterior wall of the stomach, and you can have an anastomosis without a twist. Now, closure of the gastrotomy and enterotomies. There are two ways you can close it like this, but no, we shouldn't close it like this. This is not the correct way. How should we close? You have seen me closing like this. This is the correct way of closure. So closing like this will not cause narrowing of the anastomosis. Post-operative period, on day 1, we do a hemoglobin and PCV of the patient. We do a gastrographin study to make sure that the dye goes smoothly downwards and there is no leak. And then we start oral feeding to 30 milliliter per hour. And we gradually increase it to 100 milliliter per hour in the next 24 hours. A small point of caution here: quite often the nursing staff gives a straw to the patient to have the liquids. Don't allow a straw for consumption of the liquid, because every time the patient takes a sip, the air in the straw is sucked, and this causes a gas bloat, and patient may have vomiting. So ask the patient to sip it in the normal, usual way, not by a straw. And once there is nothing much in the drain, we send the patient home on POD 2. Thank you very much. I'm open to questions and comments and everything.
Excellent, sir. Samir, can we start?
Yes, sir. Yes, sir.
Taking the privilege, Kedar and Adnik, if you don't mind me starting.
Yeah.
Thank you, sir. Thank you, sir. Thank you. It
Thank you
was
very much.
very enlightening. Many beautiful tips, common tips which you gave us. If I can go with the what you said, a few queries which I have,
Yeah, please.
and probably that will help others also. So, starting with the first preparation and the putting the patient positioning, you had the patient was on an elastic stockings, then you had put in that DVT pump.
Yes.
Why do you need the crepe bandage?
Crepe
Because
bandage,
these
see,
things
the reason
do
is very simple.
the crepe bandage.
The reason is very simple. Our DVD device, this
Okay,
it becomes a little loose, so we
loose. Okay, okay, well, got that point. I also thought that that must be the reason. I'm just confirming
yeah,
it
yeah.
that that
The Velcro has
Velcro goes off, so
yeah.
you use the.
So
Sometimes
it's
you
high
tend to
time
feel
we
that.
change it.
Right, right. Got that point. Then starting with the videos are actually the position port positions differ from slightly person to person. We use a curvilinear kind of a port positions, and we all start from the left side that way. Now, supposedly you find the pancreatic capsule adhesion. That is what you showed us later on. That if you find the adhesions, then you go from the posterior, from the greater curve, create a rent, and then again come and fire it from the lesser curve side.
Yes.
Sir, have you ever fired a stapler on the interior wall itself? Because I have seen once a colleague of mine in the hospital had fired it across, and he couldn't understand it, and he completely separated both the limbs, stomach. Have you ever fired it?
Devorsi, that
No.
was the reason I was constantly stressing upon the fact that both anterior and posterior wall have to be taken into the stapler in equal proportion.
Right, sir.
And if we take, because if there is adhesion and you keep on pulling the anterior wall into the stapler gun, that's the usual tendency. But if you do that, there will always be a twist, and it will be a clockwise, anti-clockwise twist, and the patient will vomit post-operatively.
Right, sir. So means it's a very difficult
It is,
situation to manage, and if you do not understand it on table, and it can be very difficult. That is
see,
what.
another tip at this point is you have one of your grasper in one hand. In one hand, you are having the stapler, and ask your assistant to hold the superior wall. I call it wall or the border, superior border of the uh, antrum, and you both, assistant and you yourself, pull it up into the staple gun simultaneously at the same time. Then only you can avoid this problem.
Okay. So next question is after the bougie, you have put in the bougie, you have made the first two firings, put in the bougie. How lax do you do it in a case of an MGB?
About
Because in sleeves, we stay something around 0.5 mm
yes,
away. Uh-huh.
about 0.75 to 1 centimeter.
Means it's slightly laxer than
It's
you do it in
it's
a
a much
sleeve, which
much
will come.
less than what we have in sleep gastrectomy.
That is what means. Even if you know not touching the bougie, also that is also fine. You try to stay
Yes.
lax away from it. Then coming to the retrofundal window, that's very interesting, sir. Actually, I do my sleeves also retrogastric tunnel sleeves, I call them. That is an area that is probably the area where dissection is very difficult. How often do you dissect the Belsey's fat at that area?
See, Belsey's fat I don't have to dissect because my stapler doesn't go that medially.
Okay, in a sleeve probably
In
you will do
sleeve,
it.
I have
Probably
to do. If I find that my stapler will be going that medially, I have to dissect. Otherwise, normally I don't have to.
okay. When you are doing that tunnel dissection, when you are doing the retrogastric retrofundal dissection, how do you identify the site? What I'll tell you how I do it. Means what we do is that we pick up the gastric pouch, try to locate the dimple where there can be a where which will direct us towards the mediastinum. Try to stay a centimeter and a half away from that dimple, so it takes care that we end
Exactly,
up to the
exactly,
left of.
Devorshi, that is a very standard tip. But when you
Okay,
go from behind, from retrogastric You can see this dimple very well if you are going from above. If you are
Yes.
unable to identify, then I do is I make an incision onto the peritoneum the way we make it when we are doing fundoplication. I make an incision on the peritoneum and dissect the fundus down from anterior side,
Okay.
and then it becomes very easy for you to identify and staple at the correct position.
There are two things. One is going into the mediastinum. The other is injuring the spleen, the superior border of the spleen.
Yes.
Right.
Yes.
If you go lateral, you'll injure the lateral border of the spleen, and it's going into the mediastinum.
Yes.
Which one would you like to do if you are given an
I
option?
wouldn't like to do either of them.
Either, obviously, sir.
I have to
Obviously,
be very, very
obviously,
careful. Uh,
obviously,
See,
sir.
injuring spleen is something which I would hate.
Yeah, that's
And
definitely
if
right,
you
sir.
go a lot medially into the mediastinum, that means you are very close to the OG junction, and might be even you will
Absolutely.
staple the wall of the esophagus. So both of them are really dangerous. Unfortunately, by grace of God, more than 1,000 mgb, I have not come across this.
Right. So we have fully understood your posterior 5 mm entry, that because otherwise it gets twisted. The anterior wall itself becomes the posterior wall. It becomes the point. What I wanted to say was that you showed us the arrows that you're not supposed to do an anastomosis in these black lines,
Yes.
but do it under the words probably will be that you do a gastrojejunostomy, not a jejunojejunostomy or a
Yeah.
gastrostomy. You take the jejunum up into the stomach. That is what probably should be done.
Yes.
So do you take a suture proximally, continuous suture proximally, to attach the proximal part of the jejunum to the gastric
No.
pouch remnant
No.
to prevent a
No.
reflux?
See, the
Never do it.
reflux is not prevented by that anti-reflux stage.
Okay.
Uh, if you talk to Rutledge, he strongly
Anti-reflux suture.
says that don't take that suture. What we do is you might have noticed the anterior angle that we started was about half a centimeter or a little more uh, the from the angle. So that is kind of an anti-reflux suture. It protects your anterior angle also very well, secures your anterior angle also very well.
Okay, sir. So another thing you said is that you never use a barb
I
suture.
never
We use PDS.
No. PDS
Any
I have
points where
used.
you don't use?
PDS I have used so many times, but I'm very happy with Vicryl, so I use Vicryl. It's personal choice.
Okay. We are probably more easy. PDS is more
Yes,
easier.
PDS is
And
very
now
good.
with barbed sutures, polytaxone barbed sutures, that is something which is very commonly we use it.
Devoshi, I have a point against barb suture.
Okay.
The manufacturer themselves, they say that putting barb suture on the bowel is not indicated.
Okay. Got it. The PDS is more commonly done, but
PDS
definitely
is
we have
very
used
user
it. We have
friendly.
used it. That is what
Yes,
I just wanted.
yes.
Then, slide on the first part of the surgery, omentum was not touched. Do you divide the omentum anytime? But
I usually don't have to divide. I think only once or twice I had to divide the momentum to take the loop up.
does it depends on the BMI of the person, or
In super obese, when the bowel loop is not going up and you see that there is a lot of tension, then we have to divide the momentum. I think
so?
hardly once or twice I had to do that.
So took your point very well regarding the straw, that it takes in carries in air. You do it the normal way. That point is very well taken. Sir, what about the leak test? Do you do an ICG, intraluminal ICG leak test these
I
days,
have not
which
done.
is
I have not done.
you've never done
No.
it? You still do it with a
See,
methylene blue.
the camera where my 3D doesn't have the ICG facility.
Okay.
So my 4K has ICD facility, but I'm more hooked to my 3D, so I don't do that.
So it was great, but just back coming to a very basic question regarding the MGBs, do you calculate the total bowel length sometimes to maintain that ratio which they talk about of biliopancreatic limb and the common channel ratio of 0.35 or some 0.4, 0.35 to 0.4. That is, do you calculate it?
Devoshi, one thing I tell you, I'm very conservative on my BP limb.
Okay.
Most of my BP limbs are 150.
Our average is 160 to 170.
Most of my BP limbs are 150. I don't take more than 180, even in super obese. Only in redo surgery, redo bariatric, I take 200. Never go beyond that. So if you take even 200, you have an enough common channel, and it will always be better than the ratio that is advocated. And if you measure the entire bowel length, where you find that what you have done is much more than what is recommended, even in that situation, measuring the entire bowel length may invite injury.
Absolutely, sir. Got your point there, sir. From my side, you describe my final question to you is that you describe the patient that is probably an ideal patient around 50 BMI, a male patient 55 to 60 years, uh, uh, male patients coming to you with all the comorbidities. You have done an MGB. Can you tell me in which patients are you not going to do an MGB?
I've already told. I repeat again.
Oh, sorry, I repeat.
Okay. I will not do MGB in young unmarried female who are having a little lower BMI. A young unmarried female without comorbidity, I would avoid MGB because they are going to have pregnancy, might be after 2 years, 3 years, or 4 years. And doing an MGB inviting iron deficiency and other nutritional deficiency in pregnancy, I wouldn't like. So I counsel my patients, young unmarried female, that I do sleeve gastrectomy. You reduce your weight. You enjoy your less weight life as much as you can. Have your children, and if you regain, might be after 8 years or 10 years, I'm there to convert it to MGB. I don't do MGB in a large hiatal hernia. I don't do MGB in Barrett. I don't do MGB in macronodular cirrhosis or child's B or C. I don't do MGB in past history of bowel tuberculosis. I avoid. But if I find that the bowel is okay, I may change my plan to MGB. I don't do MGB in short bowels. I don't do MGB in Crohn's. So these are my contraindications.
These are okay. So I'll share a little regarding pregnancy thing. I have done a MGB, and that lady became pregnant 2 months after the MGB. I was in a real fix what to do, what not to do, and but ultimately she delivered a 3.1 kg
That's a good luck.
baby. So I don't know whose luck it was. Only thing I told her that you stop the protocol which we had advised regarding following bariatric surgery. You eat whatever you like and whatever should be eaten in a pregnancy. For her, it was a precious pregnancy, and she delivered ultimately a 3.1 kilo baby. Over to Kedar, and Kedar, I think, must be having a lot of questions.
Yes, Kedar, how is Ossicon going?
Yeah, it was a good day, sir, today with 6 pre-Congress courses.
Right.
So thank you very much, sir, for your inputs, and you have been quite educational in showing the do's and don'ts in an MGB. So for the benefit of audience, I would like to highlight a few questions and highlight a few steps. So first is the patient selection, sir. Regarding this, you did mention that you don't do in Barrett's, and but what about when you get an endoscopy report which says small hiatal hernia, grade 1 or 2 GERD, or lacks crura with grade 1 or 2 GERD? So in this situation, do you do a cruroplasty? Do you do a RYGB, or do you still proceed with MGB without any repair of the crura or something?
I do a cruroplasty in those situations. And see, Kedar, the gastric tube is pretty long. It is about 22 centimeter. So if it is a small hiatus hernia, it is not going to cause much of a biliary reflux or things like that. But yes, a small fluoroplasty is a good option. Big hiatus hernia with, say, lot of symptomatic GERD, it's a wise decision to go for Roux-en-Y gastric bypass.
So, a few of the steps that you mentioned, I will just, for the benefit of the audience, I would like to highlight that you mentioned that the first firing is very important, where you have the equal anterior and posterior uh, antral thickness, because that is where the twist starts unknowingly. And you mentioned not going close to the pleura, incisura. And important thing about the closure of the GJ, you mentioned that we start from the posterior. I think these are very important steps for the beginners. A few questions about the technique, sir. When would you do an anterior anastomosis or transect the staple line and then do the anastomosis versus a posterior that you routinely do?
See, you can have a gastrotomy anteriorly, through the staple line, and posteriorly. I've done all the three. Anterior, it's okay, it looks nice. Through the staple line, the staple line comes in between your suture line, in between your sutures. So that's a little uncomfortable. And posterior is my standard practice. I've done all the three, and now I have settled on the posterior.
Sir, I know it's a little controversial question, but closure of Peterson's defect. Nobody practices in India, but sometimes there is occasional discussion that we should be doing this. So, what is, after doing so many surgeries, what is your take about this?
Closure of Peterson defect. See, it is a loop. When there is a loop, the chances of herniation becomes much less. If you divide the mesentery, then it becomes a real opening and it causes the herniation, internal herniation. But when the mesentery is intact, it usually doesn't cause. Over 1,000 MGB, I've never come across a single Peterson herniation or internal herniation through the Peterson defect.
And one last thing, sir, I think Devarshi sir did discuss about it, but if it were to be a revisional bariatric surgery, would you still count the entire bowel length and then decide about 200 versus any other length?
See, if I have to go more than 200 length, even in revisional bariatric surgery, I may count the entire bowel. Yes.
And after, I mean, for a hypoabsorptive procedure, is RYGB still? Are you doing RYGBs or you're just doing MGBs for?
My focus is now shifted to mini gastric bypass.
I think thank you, sir, very much, and thank you, Amasi, for this opportunity.
Thank
I
you,
think
Siddharth.
I'll hand over to Dr. Mansingh for his questions.
Yes, Dr. Mansi.
One comment, sir. When we are doing the lesser curvature window, I prefer to make that window a bit bigger. So sometimes I'm worried about the devascularizing the it at the anastomosis, but still it's very easy to look into the lesser curvature for addis. So one point that I
Your
do
voice is
is
cutting out. I
bit
couldn't
larger
get
so
you.
that you
Please
don't
repeat
take only the anterior layer. Whenever
Dr.
we do
Mansingh, I couldn't get
we
you.
try
If
to enter
your
the
voice
lesser
was cutting.
curvature.
Yeah.
So you're audible now.
Your voice was cutting. I couldn't get you. Please repeat your question.
When I do a lesser curvature, I try to enter the lesser curvature. I prefer to do a bigger window, so I don't miss and take the only the anterior wall. So that one point that I generally do is we make a bigger window so I can have a peep inside the interior of the lesser sac. So that is one
Yeah,
where
that's a very standard technique. See, the idea is not to disturb the sanctity of the crow's foot. Number one, not to go too high up. If you take a bigger window to make sure that there is no adhesion, and if your anterior and posterior wall are coming nicely into the staple, that's a fairly good technique.
otherwise you have done an excellent procedure, sir, with all the minute points being covered very well. So hardly any other doubt or any questions, sir.
Thank you, Dr. Mansi.
Sir, one last thing regarding the post-op care. I mean, for Indians to have 1 gram per kg per day, practically, I mean, Bengal, I do understand they have a lot of fish, so it's possible. But apart, is there anything else that you're doing apart from the protein supplements?
Every patient in our department receives protein and vitamin supplements, mineral supplements. Every patient.
Okay. Sir, can I?
Yeah, Debashir.
Yeah. One thing is that do you ever release that pars placida?
You can go through the pars flexida also, but in that case, there is a possibility that you injure the nerve of lateral giant.
Nerves. Yeah.
Yeah,
Matlab, to
so
make that pouch straighter, do you ever release that? Never do that.
that is not required. I have never done that.
Not required. Uh, Another point, sir. Just somebody is calling my number. If you're listening to me, how have you ever come across bleeding from the gastric remnant which is there, because we always tend to concentrate on the pouch, and post-op bleeding or something like that from
We have come across bleeding from the remnant staple line.
okay,
Number of times we have
remnant.
come across bleeding from the remnant stomach staple line. If we find it on the table, we reinforce it. One or two occasions we had to go in again because of the intraperitoneal blood, and we have found that there was some ooze from the remnant staple line, and we have sutured it.
Just suture it in, because we tend to concentrate on this side,
Exactly.
and that leaves
Exactly.
behind
See,
that
I'm very
because it is a
fortunate.
very long.
I'm very
Yes.
fortunate that I have assistant in the form of Dr. Khanna, he knows that my focus is towards the medial side, and he keeps his focus towards the lateral side.
Okay, it's a point which many people talk about.
Yes.
I have not come across, but on table I've encountered it post-operatively. Luckily, till now, my series is far less than yours, so it is. I have not come across that. Samir,
Yeah.
do you have any questions on
Uh,
from the?
I don't see anything in chat box, but sir, I hardly have any experience in bariatric surgery. But somewhere down the line, I always felt bariatric surgery is done by surgeons standing between the legs. And today I saw a surgeon was standing on the right side. First, you operated with sectoral vision, then you moved out to ergonomic triangulation. So I always feel that when you have sectoral vision, there is some limitation in visualizing of the opposite side. However, when you fired the first stapler, I think I was not right, because possibly we could see what's happening on the both sides. Rather, you rotated the stapler to understand whether they're equal also. So that was one good thing what I could make out. Sir, again, why do you use Vicryl? Why not PDS?
अरे यार मेरी नर्स वही देती है मैं क्या करूं.
No, but second thing, what noticeably I could make out that you try and suture with or take knots and put sutures with only straight forceps, where most of the people would try and prefer curved instruments. So
Yes.
any advantage, sir?
I've been using that Radic Olsen for ages together. That's a matter of habit.
And when you're handling stomach, you use Maryland forceps, which usually
Maryland was being used by the assistant to help me.
Most of the times when we teach our residents that we tell not to hold with Maryland, because at times that the force exerted and bowel is much higher.
I totally agree, Samir. But my assistant, he is there with me for more than 35 years. He knows how much pressure.
That's perfect, sir. But this is what I just thought. Maybe I could learn something much more, because this is what we always feel. That's why I said I thought master like you can guide us much more, sir. But sir, it was amazing, because now I feel I can do it. I just
you can do anything, Samir. I know.
You can do anything.
But it looked very simple to me. Rather, we always knew only sleeve. done only a few Ru and Y, but I never thought about this. So actually, this was quite
Samir, I tell
eye-opening for
you,
me.
people say that sleeve is a simple surgery, but I know sleeve has got all the possibilities of going wrong. Mini gastric bypass, there are a lot of buffer. If it goes wrong, you have a lot of buffer areas, you have got lot of ways and means to rectify. But sleeve, if it goes wrong,
Yeah, I agree, sir. Sir, we hardly have, I have minuscule experience in doing any bariatric surgery. So, learning good tips rather than learning stapling, what I could make out that you spend more time understanding whether the two jaws are adequate, both limbs of even stomach and jejunum have come together at a proper height. So, I think those are more learning points for a novice person like me in stapling, because we do more of hands-on rather than doing any stapling for anastomosis rather. So I think this was much more learning experience for us. And the surgery looked more or less very simple to me, sir. You made it very simple.
thank you very much.
Uh, I think any questions, sir? Moderators?
Actually, we started from the right side, come back
Yeah.
to the in between the legs, again go back
No,
to the right
no,
side to do an anastomosis here in this.
but he was
So
standing
we
only on
do
right
jumble
side.
out.
I
So I
was
was
constantly standing on the right side.
Acha, sir, all,
So,
matlab,
and
it's different way
when
people
I
do
was
it.
when I was making the anastomosis, I
central
shifted my camera from midline supraumbilical part to the
to left.
right mid clavicular line. So I
It
got a
was a
perfect
central vision.
visualization.
So, okay.
First two firings we do it from the right side. Then
Yes.
we for this
And then I was
First
getting a
three.
perfect
pouch making we
triangulation.
come to the center,
Yeah.
and then again ultimately go to the right side to do. And so that is true, very true with this. Yeah.
Rather learning point is have a good assistant who understands what you exactly want.
Exactly.
So
That's very true.
Absolutely.
Very
you
true.
exactly what you want.
Very true.
Rather, now I am understanding, because right now when sir changed his camera from the optical port to right mid working right side hypochondriac port, the camera didn't look like that way. Now after sir is telling me, because I always thought he's doing anastomosis with central vision.
No, no. Then it
Huh.
becomes absolute
Anastomosis
perfect
is triangular.
triangulation you are getting, no?
It was wonderful to know, sir.
Dr. Tomanas might be around. Can we have a comment from him or something?
Now,
Yes, sir.
only thing I can say is I am one of the team members of these surgeries, and I enjoyed always when Dr. Tantia performed these kind of surgery. I think MGB or OAGB, whatever we may call, this can change the scenario of bariatric surgery as a whole. When most of the surgeons started sleeve gastrectomy and switch on to RYGB, it was bit challenging. In between, OAGB can be placed, and most of the it is very replicable and technically quite not that challenging compared to RYGB, and it can be done by most of the surgeons. So these can change, and the result as such, it's very good. Except one or two situations where these contraindications are there, were nicely explained by Dr. Tantia, and Kedar put some issues. So these OAGB change the whole scenario of the bariatric management as a whole. I feel today's discussion will help our colleagues as well the future prospective bariatric surgeons. It's a nice evening together on this Zoom platform. Nice,
Yeah.
fantastic.
Sir, can I add just one point, sir,
Yes,
Tamana, sir, to
Please.
your comment that when experts like sir do it, looks very easy, but the learning curve for bariatrics for all the beginners is 30 cases. So you need to have a mentor for 30 cases and then probably do it on your own.
Exactly. Still, I remember at the very initial part, we had a lot of challenges. Even patient positioning, how much we can go head up, how much tilting. These are all challenge. How we can fix the patient with the table, because we take a very stiff head up. And that time when Dr. Rudlej came to our center, and he explained certain things which can make subsequent procedures how easy. So mentoring, definitely none of the bariatric procedure easy. We cannot take that it is very easy. I am just talking about transition from a sleeve to ROIGB. MGB can be placed very nicely as an indication wise as well technically. That is my proposition to give our audiences.
Yeah.
And
Thank you, sir. It
Thank you.
was wonderful, sir. It was really wonderful. For a novice person who doesn't understand bariatrics, it was eye opener.
Samir, don't try to be so
No,
innocent.
sir. We don't have hardly experience in bariatrics, sir. Hardly any experience, sir.
So we can conclude today's session.
Sir,
So will you do?
yeah, sir. Before we conclude, another advertisement of our forthcoming event, sir.
Yes. Please.
Yeah. Give me 1 minute, sir, please.
Please run the advertisement. Yes.
So I again would remind everyone for our forthcoming events, the mega event which will be AMASICON 2025, which will be at Jaipur from 28th of August to 31st, attended by most who's and who's of minimal access surgery from all over world. So just register to be a part of it. You will get to see surgeries, good amount of panel discussions, symposiums, and yes, best video and best paper presentations there also. Amasi Online CME, which happens on first Monday of every month. On 6th of March, we have Dr. Chernoskowski, who is speaking on locally advanced rectal cancer, which involve the bony structures. What would be the approach? It's at 8 p.m. on 6th March. Amasi Lens next month would be on robotic thoracotomy, minimal edit video by Professor Nyan Chand from SGPGI endocrine. He's a professor in endocrine surgery, SGPGI. Again, it would be at same time at 7 p.m. on 20th March. Amasi holds specialized training courses. Forthcoming is going to be MMAS in colorectal, which will be held at Kochi by Dr. Prakash Kurumkul. Online lectures will be from 24th to 26th March, and on-site will be from 28th to 30th March. Another specialized course in HPB surgery. The course directing being Viju Kotakat, which will be the physical will be held from 4th April to 6th April at Puducherry Jipmer. The online lecture will proceed from 31st March to 2nd April. So please register if you are interested. The most awaited MMAS in the hernia, which will be held at Jaipur. The online will be from 19th of May to 21st, while physical will be on 23rd May to 25th May at Jaipur. So interested people, please register for it as early as possible. Thank you. So I take the opportunity to thank Om Tantia sir, who at one phone call agreed to educate us regarding mini gastric bypass. This was a good eye opener or good learning point for at least a person like me who doesn't understand bariatrics at all. I would like to thank Debarshi sir, Kedar Patil, and Mansingh, who all, though busy in lectures and theaters, even conferences, Kedar, in between conference, agreed to participate and moderate the session. And at last, I would like to thank Tamona sir, who also passed the set of Amasi. I missed on him because I did not understand. He had logged in initially. He was supposed to welcome all, and I just started because we were on time. So I really apologize. But I still need to at least join the session and be a part of it. So I hope we again meet on this platform. First for online series on 6th of March, and 20th March will be Amasi Lens, same time, which will be with robotic thoracotomy. So thank you all everybody on behalf of Amasi team. Hope to see you again. Thank you, sir,
Thank you.
for excellent demonstration, and thank you all.
Thank you, sir. Thank you.
Pashupati, please play the video, please.
Yeah.
I think I should thank Merrill also, because they have been kindly
Yes.
supporting us for each and every online series.
What was a visionary
So let me thank the entire Merrill team for being kind-heartedly supporting our online series and Amasi Lens, and they have been a good part and partnering us in promoting education, not only in online but physical, even in the Gen Next programs and other skill courses. Thank you, Merrill. So please play the video.
What was a visionary dream has now blossomed into the realization of a globally renowned medical device powerhouse. What evolved from a modest beginning now operate one of the most cutting-edge facilities in healthcare. What once was a single venture has now proliferated into a presence in 6 distinct domains. What began as a modest collection of products has flourished into a portfolio of over 200 diverse products. What was conceived in one country now operates through more than 150 nations. What started with a few inspired individuals has burgeoned into a global team of over 10,000 plus dedicated medtech professionals and underwent an evolution, experiencing substantial growth to emerge as a dedicated brand poised to address the healthcare needs of this world. All of this made possible through achieving comprehensive excellence in all domains. By embracing modern innovations that enable to win the hearts of healthcare providers and patients across the globe. The progressive transformation of the infrastructure has seamlessly mirrored the pace of technological advancements, culminating in an unparalleled achievement of elevated output and precision in production, setting an extraordinary standard within its niche. Welcome to Merrill Endosurgery, your one-stop surgical solution empowering excellence across oncology, bariatric, thoracic, gynecology, urology, gastroenterology with innovative and reliable instruments. From precision cutting tools to advanced energy devices, we deliver comprehensive solutions for modern surgical needs, ensuring safety, efficiency, and superior patient outcomes. Introducing Mirus, range of stapling products. Powered endoscopic linear cutter. Endoscopic linear cutter. Linear stapler. Linear cutter. Circular stapler. Hemorrhoid stapler. Monic trocars. Eliaro trocars. Eliaro bladeless trocars. Introducing Merrill hernia portfolio. ITAC A. Apsimesh. Merigro mesh. Philiprop mesh. Philiprop mesh soft. Marinium mesh. Profound N. Profound A. Mesic energy device. Mesic compact ultrasonic. Mesic laser. Mesic ultrasonic. At Merrill, we don't just innovate, we empower. Together, let's create.
So thank you, everyone. I think it's long day for everyone. I think we take a leave. Hope to see you again for next Amasi online series as well as Amasi Lens. So be in connect. Visit website to understand future programs also. Thank you.
Thank you, everybody.